I certainly think that everyone over the last decade has heard the word missed and sort of, where we've come and where this has grown, added to the fact that, in the next 10 years, the aging population, 60 plus, will double or triple. And from some of the work that we do with our AUA census, there's no way we're going to keep up. There's no way we're going to be able to treat everyone with BPH. It's just impossible. Here's my disclosures, and I like technology. I love BPH. My mentor, Dr. Ween, put up his, I have a few others, but at least who I hear is still in the OR. My first days of learning BPH was a hole-up. And after about 3 years of doing hole-up as a medical student resident, then I learned how to do a TURP. So you can imagine how traumatizing that path was. So everything's a hole-up and everything's to that degree. And the research that he did, and he's led me to partake in the guidelines, sort of a hidden member of the AUA with some of the work with Dr. Lerner and directly with the Canadian, your little brothers up north that look down at the States and love your TV shows and so forth. But as Canadians, we're 1/10 your size and have a different structuring. So kind of like the idea that, with bladder cancer, we got you got some BCG, and if something bad happens, we jump to a cystectomy, like this huge jump where, if we go watchful waiting, which no one really does, we can tell them to cut back on your diet, but everyone likes to take a pill or surgery. It's human nature, especially men, we're kind of lazy. No one really does the weight loss. No one really cuts back on 8 cups of coffee. They just kind of look for, what pill do you have to give to me? And then if we need surgery, well, most people have 1 or maybe 2 options. And that's just because, well, I've got tons of other techniques and other diseases I'm managing, and BPH tends to be sometimes a filler for residents, and at least in academic programs. Enter missed, and I think this is where we're looking for something that's going to be in the office, easy to do, quick, right? We all want Amazon now. Click, it's here in 2 days. That sucks. That was here tomorrow. That's just what we have as a mentality, and we don't want to have anything that it's not going to cost us anything. Whereas with TURP, we didn't even talk about it, but you're going to lose your ejaculation. But he's 70, he doesn't care, and we've published on that. Yeah, 75% of men that age really would like to have that sexual function maintained. And since that point, it's not just yesterday, but in the last 10 years, we've had, the FDA approval for, UroLift, and we'll talk about that next, which is a permanent compression based on the grappling hooks on the capsule and so forth. And, some of the data we'll see and question, is it durable? Is it something for middle lobes? Enter now thermal. We can add in heat, and that will create a slow process, kind of like watching grass grow, that over the next couple of weeks or months will be shrinking the prostate. One of the few and only myths that actually changes prostate volume. Then you have these other idea that we can create and reform the circular tube of the urethra to be a taller tube and have less resistance. So these temporary, either mechanical with pressure, which is the iTind I'll talk about, and Garrett's going to be talking about some of the cool new abrupt, fast, mechanical reshaping, creating an anterior commissurotomy with the optimum BPH. And guess what? It ain't over. Like, if you guys are going to the AUA and you're going to hear about all these other stents, which are right now in clinical trial, 2-year data is accruing now for the ZenFlow, which is this kind of like, if you don't like your shoes, we'll take it off, we'll put a new shoe in. It's not meant to be embedded. It's going to be easily taken out. And there's different sizes. There's Pro-V and a few others as temporary stents. And Dean Elterman and I, and we kind of joked, and you can see in the upper right corner, the quest for the Holy Grail is we want that. We want something really easy that you can just right there in cysto, like an angiogram. Everyone goes an angiogram. Well, guess what? They always find a little something, and hey, right there, just throw it in, right? You're here, you're right now. We got his stuff, and let's fix it now. Versus, in Canada, we do an ultrasound, you just cysto, and then 6 months later, we may get to a decision, then you're on a wait list. So I think this is what we want, something that's going to be easy, cheap, that doesn't require, advanced technology, a pediatric bronchoscope, or, a whole other set of equipment. So let's talk about iTind. So this is supposed to be a temporary nitinol device devised by Ido, I can't remember his last name, is in Israel, sold at over $375 million from Meditate to Olympus just a few years ago. And the simplistic idea that this is an intertwined nitinol device, kind of like braces, that's going to put pressure at the 12 o'clock position, the 5 and 7 o'clock position to create these grooves athermally. And it's based on, if you guys remember your physics laws of a tube, there's Pusui's law, which is based on the length Well, we can't change length. We can't change temperature, which is another factor. The only thing we can do is increase the radius, either drill a hole through it or increase the height. And so that's what we're trying to do. And if you think about anteriorly, what's nice about that, there's nothing there. There's no big blood supply. We're not dealing with the ejaculatory ducts. It's just anterior space. So this is a quick, efficient device that's really not as noxious as some of the other invasiveness. And I'm able to do this in an office setting, kind of like a cysto, where you will position first a guide wire and then place in a 12, 14 access sheath, and then introduce this compressed, almost like a birdie in badminton. It pops open in the bladder. Then you go back in with your cystoscope, pull it back, and then reposition it. And your marker is going to be a blue marker on the top of your plastic device. And it looks like a shepherd's hook. For those who used to lifeguard, you pull out over the bladder neck, sit in front of the vero, and you're done. And you leave a string outside the penis. So there's no Foley, which most guys are appreciative. Downside, one size fits all. It's like Cinderella's shoe. So is it going to fit everyone's foot? Is it the right angle? Well, this is where patient selection is key. And so this device is cool, but it's not going to be for your middle lobe. It's not for your 60 plus gram. I think their data is up to 80, but it tends to be for the smaller prostate. So here's a small little video inserted. First, our flexible cystoscope. Some people do this with a rigid, but I'm doing this in the office. So to make the patient comfortable, requires a guide wire, then your 14 French access sheath, which tends to be as expensive as some of the guide wires. And then from that point, you're using that as a depository for your stent that you'll place in, and then it's really like a triangle. You'll first bring your scope in. You want to rotate it so you can see that isosceles, like there's your shepherd's hook, and you're just going to simply pull back. I've learned that 3 sets of hands are better than 2. So if you have 2 nurses, want to squeeze the bag, especially when you're here and you're pulling that shepherd's hook, this is when they're feeling it. It's quick, it's short, a little less than maybe the Optilume. It requires a little bit more time of pressure at higher atmospheres, but this is easily placed into the loading position, and then you just leave it there. You tell them not to cut the string. I've had one string rip off. That was tough. So the end of the device doesn't have a very jagged gripping point. It's a very soft, rounded piece of plastic, which is good for their sphincter, but when you want to remove it, and if somehow the string has been cut, you may need general anesthesia. I would not, I don't know if anyone here has had experiences of that, but I've had one, and it was as traumatic for the patient as it was for me. You're sitting there awkward, almost like that awkward vasectomy where you're like, I can't find it. He's awake looking you in the eye, and what do I do? So I brought him to the OR under anesthesia and pulled it out, but it was tough. So again, it's a device. It's really meant to put at 12 and 5 and 7 o'clock. And the analogy I give to my patients, and same thing for the Optilume, is we're trying to create not a hole. We're not going to punch a hole through the prostate. We're just going to make it taller. And all of us, when we travel, we're going to get something from our bag. Well, you open the zipper, or you get that secondary zipper, and wow, not much resistance. It just takes a little bit of extra space. And you're really doing it at the 5, 7, and 12. And here you can see on ultrasound what that looks like and compare that to the Optilume. So what's cool for the Optilume is I think there's even more of a crack. We haven't really measured the aperture of opening, but we know that's a 3.5 centimeter height and 5 centimeters long. Does it create that height? I cannot say. But certainly the data shows that at up to 3 years that it is a device which has good efficacy, no impact on ejaculations or erections, there's no heat. And I call it like joking with my residents before, the Zorn factor. Does this have something that's reproducible? If I take everyone in the any surgeon here in the room, and I said, you guys, day after day, you do the same procedure, will you nail it? Are you gonna do the same procedure on the same patient, the same way each time? And between us, can I guarantee that if everyone here on the panel says, I did an iTind, we know that technically you will do an iTind, like the hole up. There's only one way to do a hole up. The same can't be said always for the other techniques where there's a lot of hand, gesture, angle, pressure, number of sticks. So there's going to be a lot more variability between one surgeon to the next. I think that's something important too when looking at outcomes. Does the surgeon play a role, or some of these technologies, it's agnostic. Aquablation, Optilume, as long as you have a hand to twist a device. I was joking with Garrett, is you have one eye and maybe an arm to hold the device, that you can do this. And I think the results are because of the technology, not by the surgeon. So there's a more democratic type of outcome. So again, key things here, it's quick, it's easy. It takes me 15 minutes to set. Guy comes back a week later to take it out over a catheter. And the recovery is quick because there's no heat, there's no thermal impact, and there's no negative influence on sexuality. A little short view of some of this thing we'll probably be seeing at the AUA and EAU with 2-year data. The ZenFlow, 4 different sizes, quick and easy. Again, the whole idea of a T-mist that has an impact, but again, it's a device that's in place. Now moving to the Rezum, my second task here, I'll go through this quickly. By showing of hands, does everyone in the room, has everyone here done Rezum? So, okay. So again, the principle is quite simple. As long as you have a finger, you can push a button, you bring out that small needle, it injects over a 9-second period, 208 calories. That's what they call it. I guess they measure it. It sounds like we're having a diet, but how many calories do you get? So you're doing, between 4 and 6, and in Canada, that device cost me to the patient $2,200 Canadian, so about 1,800 US. Versus the UroLift and others, that would be sold through to me to the patient at $900, almost $1,000 a suture. So if you want to put 6 or 8, it becomes very different in terms of a cost. So from a Canadian perspective, quite a nice opportunity to have one device, which we can technically do 15 9-second treatments or more if you don't do the full 9 seconds. So does a good job. It's really the few things that can attack the middle lobe. It shrinks the prostate from the first in man studies around 30%. So it's one of the few myths that it can address and tackle the middle lobe, anticoagulated patients. And for me, some patients who are really like, I want an aquablation, but sir, you're 91 years old, you just had a fresh stent, I want to do this on you, I don't think it's safe, but we can do this, and instead of shrinking your prostate 60%, we can get it down 34%. And if it doesn't work, well, we can still do the other techniques. So with it, we have shown in our data, Dr. Eltimer, myself, and a few others, on average, we're shrinking the prostate around 35%, and that's over a 6-month period. And even when we looked at the above 80 to less than 80 grams, similar, about 30% reduction in volume. It's quick. Typically I do these again in an office setting where I'll do the periprostatic block, a modified Bear's technique. So under the seminal vesicles, I'll spear through the seminal vesicle and inject the lidocaine between the bladder, so you get that afferent vessels along the neurovascular bundle, which technically we want to freeze the transition zone. So if anyone here has heard of the Shalin catheter, not yet available in North America, but wow, what a godsend that would be, because you're really freezing the area you want to do with the treatment. You're not injecting lidocaine at the seminal vesicle and hoping it diffuses to treat the transition zone. So I think that's something that we should consider more. But again, the key thing here is that it does make a difference in the IPSS and the Qmax for shrinking the prostate. But take a look, it takes a couple of weeks to get there. It's not an Amazon now. So the way that I like to explain to patients, it really doesn't influence the erections. If anything, I've had a few people have better erections because they're off their medical therapy. And we don't always think about that in terms of the patient journey and the multitude of different aspects of bladder and pelvic floor function. It does, I would not say zero. So if you really have a guy who's like, I got a young wife, we got to get her pregnant, I would not say this is 100%. You got to tell patients 5 or 10% chance, especially the guys who are in retention. I tend to overtreat because you really want to get them open. And this is the whole idea that the adverse events, if you look at the brochure, there's a guy running, and I'm like, it's not the image you want, right? I think everyone here who's done Rezum knows what I'm about to say. You got to set the expectations. It's like having a chemical peel, or you want a nose job. It ain't going to be pretty up front. You will get there at 3 months. It's an amazing long-term durable. No one's going to disagree with the data, but to get patients there, unless we can hypnotize them for the next couple of weeks, they may not be as happy. And for that reason, Dean and Eltimer and I, we tend to leave the catheters longer, up to 2 weeks. We used to be a week or 10 days, or you kind of negotiate with the patient because they hate the catheter. But if you take out the catheter earlier, then the phone rings, and you get the upfront, maybe you get the catheter back. You're setting in cultures, giving antibiotics. And this is my sort of personalized slide. I think everyone here who does Rezum will have a smirk when I say this. But you're going to have, the catheter longer than other techniques. You're going to get more nursing phone calls. They called in, it burns, and you probably here's some antibiotics, or maybe you'll get a culture, it comes back and everything under the sun. And I call this uropsychology, and I guess maybe it leads into what Dr. Wiener was saying, that there's a whole other element that, BPH is not always a benign type disease. These patients are sometimes traumatized, they're scarred, they're injured, they've had catheters, at least in Canada for up to a year or so. So the uropsychology element is higher, and at least in my practice, we tend to do a few more cystoscopies, and sometimes you're going in and sloughing off some of that, I call it like therapeutic cystoscopies. So again, the data is there, it's strong evidence, it's amazing stuff. I've seen some great results, but I think it's a lot of patient preparation. But the bandwidth of the patient offering is quite large, from the frail to the large, to the smaller, to the middle lobe. Compared to the iTind, this is a mist that has, a jack of all trades. It's like the Swiss Army knife. So the 5-year data is there, 30 to 80, and certainly more than 80. COVID helped us push that. Men in retention, we have strong data. McVary, Elterman, myself, with over 80% at 1 and 3 months being catheter free. The downside, again, a little bit longer catheter stay. So a lot of this, I think, leads into what we're saying with the ultrasound. I think everyone should be doing ultrasound, but we should be doing something more than that. BPH is not all the same tissue. There's a mixture of stromal and glandular. So anyone who enucleates will know exactly what I'm talking about. When you're stuffing that needle in, and one poke, you hear it sounds like a nice small, it's a hymn. You poke another centimeter later, the whole patient's vibrating. You're hearing hissing. You're like, did I hit something different? Yeah. You're hitting stromal and glandular tissue, and we're really not taking the time to think that these also will respond differently to temperature. So if you look at the Rezum data and look along those slices, a lot of different widths and amounts of necrosis that you'll see, and some patients post-op are going to come back and bring us big chunks of tissue. Some, hey, I didn't slough at all. And it's hard to predict who it is, but I think that's where we need to go. We need to go beyond the caveman XYZ volume, and we need to get into a PIRAD system. How much money do we spend on prostate cancer? When it comes to BPH, not everyone does an ultrasound. It's like it doesn't make sense. So I think we need to get to beyond imaging, but to also understand what are the type of tissues we're dealing with. Is it plastic or cement? And someone who's got a very stiff prostate may not respond to a stent and may need resection. So it comes down to the personalization, and that's why I think I'll finish off on that and hand the mic over to Gary.